So I've been asked to talk about the combination of chemotherapy or radiation therapy with immune therapies. And one of the first questions that we do have to ask is, how can chemotherapy enhance the immune response? If we're going to combine these two agents, we want to know, what can chemotherapy contribute to the immune response? And the major mechanism appears to be that it may help release neoantigens. When you have dying tumor cells, you release more neoantigens. And in addition, there are potentially other mechanisms in play. Release of neoantigens from dying cells can occur via many ways from chemotherapy, but if your chemotherapy drug induces this immunogenic cell death, that is even more ideal than other ways that cells die. And finally, we're learning more about how chemotherapy might be able to influence the immune environment. Everyone is very familiar with this underlying slide here, where we know that the somatic mutation rate correlates with specific tumor types. And this is the rationale for why we believe that we're seeing these high response rates in lung cancer, because of the high mutational burden. But more recently, this figure has been modified to include the estimates of neoantigen formation. They're tightly regulated between these two. And you can see here that in the green box, the more frequently ability to form neoantigens at 10 mutations per megabase is with melanoma, and again, not surprisingly, then you see this list here to where lung cancer falls in, where you regularly see formation of neoantigens, and then below 1 occasionally see neoantigen formation. Now, we know that the majority of mutations do not result in neoantigens that are recognized by T cells. So any ability that we can give the immune system to see more neoantigens via perhaps cell killing by cytotoxic agents certainly would be worthwhile. And we also know that here again, talking about the Nair-Rizvi science paper, that neoantigen burden does correlate in this small example of about 30 patients based on his delineation of what he felt was durable clinical response versus minimal response, that neoantigen that neoantigen burden was significant in those patients who had this durable clinical benefit versus the minimal clinical benefit with this lower neoantigen burden. And so moving to immunogenic cell death, this is something that I was not familiar with until I was giving another talk on this in the summertime. So I looked this up. This is, again, a form of cell death. It's capable of activating an adaptive immune response and capable of inducing immunological memory due to the fact that it's releasing these dead cell-associated antigens. And it's a very fascinating pathway. It relies on this endogenous danger signals from these dying cells, and it's important in how the release is occurring. It generally manifests as an apoptotic cell death. And there are several cytotoxic agents, molecularly targeted agents, radiation therapy that can elicit this immunogenic cell death. But I will tell you that no cytotoxic drug for lung cancer is on this list as being a bona fide ability to induce immunogenic cell death. Now, having said that, there is a lot of research going on trying to develop drugs that can exploit this danger signal pathway to be able to then convert a chemotherapy drug into one that causes cell death by this immunogenic pathway. And then finally, emerging data about the role of chemotherapy's influence on the microenvironment. We are probably most familiar with cytotoxic agent Cytoxan in trials where we've given vaccines for lung cancer, and we give that low dose of Cytoxan because we're trying to inhibit the T regulatory cells. But in addition, we're now learning that there are other ways that gemcitabine, I put here new evidence for cisplatin and paclitaxel that may also be inhibiting these myeloid-derived suppressor cells. as well as other agents that can have an influence on T cell priming, and then as well as these tumor-associated macrophages. Well, what is the preclinical evidence for combining the two drugs? Here you see one of many models out there, and this is one that Ross Camage had shown at the World Lung Congress, where here again you really do see this very nice, durable growth inhibition with the combination of an anti-PD-L1 and a platinum chemotherapy agent. Clinically, the first example of the combination of chemotherapy with an immunotherapy was reported in 2012. This is a trial run by Dr. Tom Lynch, and it was with ipilimumab and paclitaxel and carboplatin. It was a randomized phase 2 study where they looked at the paclitaxel 175, carboplatin 6, and ipi in a phased sequence where they gave 2 cycles of the chemotherapy, then they added ipi to the chemotherapy on cycle 3 versus giving the ipi up front on day 1, cycle 1. No benefit for the concurrent, and benefit here it met its primary endpoint with the phased. And of course, this phased sequencing was done because of this mechanism of trying to have additional tumor release from dying cells. Right. Overall, we know that ipi does cause a lot of toxicity. That was true in the concurrent arm, but in the phased arm, grade 3 and grade 4 toxicity was really very similar to the control arm, and there has been a randomized phase 3 trial that has completed accrual in non-small cell lung cancer. There have been 3 studies. There are feasibility studies looking at PD-1 and PD-L1 inhibitors in combination with chemotherapy. Here's the first one that was presented looking at GEM-CIS in squamous cell, PEM-CIS in non-squamous cell, taxol carboplatin with Nivo 10 or Nivo 5 in any histology. Small numbers of patients. Overall 56 patients. You can first of all see that there was really no increase, I would say, in immune-related toxicities. There was a little bit of rash here, but we're not seeing colitis. There was maybe for diarrhea 1. There were 7 patients who developed a pneumonitis. There were no toxic deaths, but overall I would say very well tolerated. Most of these side effects here coming from the chemotherapy portion of the combination. Here's the waterfall plot showing activity, showing tumor shrinkage, and then overall you can see that there is some hint of activity here, albeit these numbers are incredibly small. The response rates ranging from 33% to 47%. You really cannot make much of this in these small numbers. No difference in outcome by PD-L1 expression. Turning now to pembrolizumab, similar, they looked at paclitaxel carboplatin or PEM carboplatin in combination and then followed by maintenance. All of them included a maintenance inhibitor. Here I think you can see these are grade 3, 4 toxicities, very, very mild toxicity here, mainly in single digits. And as well, you see the waterfall plot showing activity, tumor shrinkage. And here's the overall response rate. It certainly wasn't impressive if one looked at the paclitaxel carboplatin here, but when one looked at the PEM carboplatin, overall a 58% response rate, you do see this more durable treatment exposure and duration of response here for the pembro carboplatin arm versus the taxol carboplatin arm here. And then finally with the atezolizumab, looking now at the same 2 regimens, but in addition looking at nab-paclitaxel plus carboplatin. I'm sorry you can't see this very well, but what it shows is that the predominant grade 3, 4 toxicities are hematological and related to the underlying chemotherapy regimen. No episodes of pneumonitis. Now, here again, we do see this hint of activity here with the combinations. Very, very small numbers, however, But overall, again, this is 67, 62, 75, very, very small numbers. So based on this information, though, there are several phase 3 trials ongoing looking at the combination of chemotherapy with or without an immune checkpoint inhibitor, followed by maintenance immune checkpoint inhibitor, and I'm not going to discuss that any further. Of note, any PD-L1 status is being employed. I will say that I've not seen any other additional biological correlates from any of these phase 1 clinical trials. Maybe some of you all know additional information there. Finally, I want to turn briefly to radiation therapy. Our radiation oncology colleagues certainly have known for many years that radiation therapy is an excellent immunomodulator, and here's a whole host of ways in which radiation therapy influences the immune system. Here again, the release of the tumor antigens, the secretion of these danger signals, the immunogenic cell death, and most importantly is the proof of concept clinically is this effect called the abscopal effect that Dr. Gajil had already mentioned, where you radiate one site and then you see responses in another site. And here's just an example looking at radiation of the liver, to where you then see this patient had all these pulmonary metastases, and then after that radiation, those pulmonary metastases are gone. Now, this is a very rare phenomenon, but it does speak to the immunomodulation of radiation therapy and gives us now an opportunity to exploit that and build upon it with combinations of immune checkpoint inhibitors. And here's some recent preclinical work. They're in a xenograft model. This is a melanoma model showing the significant benefit in combination of radiation therapy plus a PD-L1 inhibitor, as well as we see that the tumor antigen-specific T cells are increased with the combination, and this is also highly statistically significant. And this is a very exciting area. There are several clinical trials that have really just now launched in this area in lung cancer, as well as many other tumor types. Radiation therapy, because it's given over a limited period of time, I think is a very good partner. There are lots of questions to be asked. What type of radiation therapy should we give? Is it SBRT? Is it conformal? Where should we do the radiation? Is there a difference between radiating a liver lesion versus radiating a lung lesion? And also, what about sequencing? And here is my own trial that has been launched looking at the sequencing issue of giving the combination together concurrently, giving the immunotherapy first, then followed by the combination, or giving the radiation first, then followed by adjuvant PD-L1 inhibitor. As well, we have a lot of biological correlates in this study, including we are collecting stool samples to look at the microbiome. So in summary, I think I have hopefully shown that there is at least some biological rationale for combining immune checkpoint inhibitors with chemotherapy and radiation therapy. The early phase clinical trials have demonstrated that they're feasible and they're safe. I think we cannot make much of the efficacy data. They're very small numbers. We will have to wait for those definitive results from the phase 3 trials. And feasibility trials with radiation therapy and immune checkpoint inhibitors have been launched, and I think that's a very exciting area to keep your eye out on. Thank you very much.
So Paul Bunn and I are among the few people here that are old enough to remember the first phase 2 trials of Taxol Carbo that had 50 and 60% response rates, and we were saying, wow, this is great. Now it's actually like 30 or whatever it is.
Right.
So
well,
that was your study too,
It was
right?
actually Corey Langer's study, so that's exactly why I really have to be cautious when we see the 60s and 70s. You have to take that with a grain of salt.
Yeah, it's just the Lake Wobegon effect, and all of Karen Kelly's patients do better than average.
No. They have nothing to do with it.
So any questions for Karen? Okay. Jamie, chat.